surgeons are very well aware about this. 91 high-grade sarcomas all had chemo. Local recurrences with RT there was nil, and without RT it was 22%. In low-grade sarcomas also with RT there was 1 recurrence, and without RT there was 8 recurrences. So this is a level 1 evidence of randomized study which shows us yes, in adjuvant, as an adjuvant therapy, radiation therapy is extremely useful to prevent local recurrences. Does it stop with only local recurrences? We also see some of the data which came out from the systematic overview of the radiation effect from soft tissue sarcomas of nearly 4,500 patients. Similarly, it says that local control of 90% can be achieved. Again, reconfirms addition of radiation improves local control irrespective of whether the margin is negative or marginal or minimal microscopic positive margins. Now, they also published the recent data in 2008 wherein Scandinavian people said that over the years from 1996 to 2005, the rate of radiation use has increased and local recurrences have decreased. It is not because there is an increase in wide surgical margins. They believe that yes, addition of radiation significantly reduces the recurrences. RT effectively prevents local recurrence irrespective of the tumor grade, irrespective of the depth of the tumor, and it is more effective in high grade deep soft tissue sarcomas even when the margin is negative. And MSK13 developed, can you get it right? MSK13 developed a nomogram just to say this, that age is a factor, size is a factor, margin is a factor, grade is a factor, histology is a factor. Going on to this point, if you take high age more than 50, size of more than 5 centimeters, margin close or positive, high grade, and other than lipoma, liposarcoma or well differentiated liposarcomas, when points are added up here, you get to somewhere around 360 points on the scale, and 350 to 60 points comes to a recurrence rate of 40 to 50% at 5 years and somewhere around 50 to 60% at 10 years. So we have a nomogram developed by the surgical data from MSK13 which helps the surgeons to decide whether the presence of radiation oncologist is helpful in the particular case wherein he has done the surgery. Now, not only that, there is a step ahead. There is a major data which came out from the SEER data of nearly 7,000 cases, 1998 to 2005 was analyzed, published by Koshi et al., and this is published in 2010. Here, 47% of the patients received radiation. It is extremity soft tissue sarcomas, limb preserving sarcomas, addition of radiation in high grade and especially high grade and more than 5 centimeters, addition of radiation improved the overall survival. This is the only data which says, as of today, which I have come across, which says addition of radiation improves the survival. Till now, we have the data which says, that is level 1 evidence which says local control is superior when you add up RT. Here, this is not a randomized study, but this is still a good major SEER data which says that yes, addition of RT probably can improve survival when in simple single institution studies or level 1 studies are not possible with this institutions having smaller numbers. This is worth for us to look into. Now, having seen that yes, radiation has a big role, how do we now go about assisting the patient? You do a wonderful surgery, you are able to produce a limb where the patient can use it wonderfully well as if it had never happened anything to him. Now, I as a radiation oncologist who should produce not a recurrence to him, but at the same time not impede his progress in life by reducing his mobility, either the leg or the arm or let it be any part of the body. What do we have with that? We have advances in treatment like IMRT, like brachytherapy, like IORT. This IMRT, intensity modulated therapy, concentrating the dose, available literally in many centers in India, including our center which we practice. Brachytherapy, again available, it's restricted, not like what we have in IMRT, it is restricted, that is using brachytherapy, intraoperative application and then delivering. Brachytherapy is available, but using this for a sarcoma, much restricted, but it is available. IORT, practically in India we don't have. Internationally also there are only very few centers who use the IORT. What does this do? These advances in therapy tailor the conformal dose, whatever we want to deliver. For example, this is the probability of the cure or toxicity and this is the dose. Increase in dose increases the cure. I want to achieve a cure of 90% and this is the toxicity curve, curve B. If I want to achieve a cure of 90%, I get into a toxicity of somewhere around 50%. Now, I want to push this toxicity curve from here to here, so 90% cure, 5% toxicity, it is feasible because of high conformal treatments. We deliver high doses, possibly increased local control and a cure. And number 2, this normal tissue volume exposed to high doses is reduced. So the very critical element is reduction in toxicity, both early and late, and each one of them is possible we can do with this. Now, how do we do this IMRT? Now, important thing is patient positioning. You do the surgery in 2 to 3 hours, anesthetized, no movement, you are comfortable. Like that, we have to be comfortable for 5 weeks or 6 weeks. Perfect positioning is required. We use various sort of fixation devices, let it be for the chest area, abdomen area, head and neck area, or for the lower limbs. Perfect fixation device is required, with which we do the CT scan and an MRI, with which we go through the entire course of treatment for 6 to 7 weeks. So proper patient positioning, and then with this itself we go ahead with a 3D planning, MRI and CT scan. In our institute, in our department, it is compulsory that all our patients go through MRI and CT scan for defining the target volume, followed by planning and treatment. Now, RTOG, EORTC, NCSAI, all have combined together, produce the data using external RT. How do we decide the volume? This is taken into consideration, the surgical data. In fact, they have taken into consideration, one of the important things they took into consideration was 15 cases which has been underwent an MRI followed by surgery, and MR based extensions and surgical things were correlated, and they found out that how much margins we had to give beyond the tumor. You people, when you open up the patient for surgery, you don't see the tumor, you go around remove it. Same thing like that, we have to go extensions beyond the tumor. Now, in an MRI, GTV is always, we now prefer, and what is advised as of today, we identify the gross tumor volume, GTV, only in the MRI. So we do the MRI, identify the GTV, and once it is identified, this is fused onto the CT scan which is done for the planning, and then we do the planning in that. We do contrast enhancing in the pre-op case, we do contrast enhancing under T2 MRI. In the post-op, directly we do only T2, and here the gross tumor volume to be treated is the tumor bed. If this is going to be the gross tumor volume, the possible extensions, the microscopic extension, like you give a margin, we give a margin, and the margin is around 1.5 centimeters all around, restricting it in the fascia when it is not invaded and in the bone, but craniocaudally we give a clearance of around 4 centimeters. Okay, having done this, this is going to be the clinical target volume, the second line, outer line is seeing, then irrespective of the best immobilization we achieve, still there is always a possibility of patient setup errors. So we account something called as a planning target volume, which we identify here, for which we give a margin of somewhere around 5 mm to 1 centimeter. So this is literally going to be our volume if this is going to be the tumor area identified on the MRI. We go ahead, and this is one of the literature data wherein we also, whenever the surgeon does in post-op cases, whenever the surgeon does a surgery, we request, and our surgeon always do our metallic implants are there always, wherever always the clips are placed by the surgeons to decide cranially, caudally, medially, laterally, and the bases. Multiple clips are placed, and it helps us a lot in deciding the volume to be treated. We always take the clips also into a volume, that is into the GTV, CTV and PTV, and we go ahead, we plan it, and the dose is again 50 gray for a pre-op case and around 60 to 70 gray for a post-op sarcoma. This is one of our cases wherein we have a T2, the tumor identified in this, and it is transferred on to it is marked in this, it is a different section, and transferred on to the CT scan, and we create the GTV, we create the CTV, we create the PTV, and this is the PTV which is planned for treatment. We go ahead, plan it, deliver it. This is an IMRT treatment for this patient, and this is a case which we had treated retroperitoneal sarcoma adherent to the IVC, not operated. This patient was unwilling for surgery, so we went ahead with treatment. He was a 36-year-old man. We went ahead and treated, and with this, a dose of around 60 gray was given, and in the inner parts of the tumor received around 66 gray. The kidneys escaped from the high dose region, and it is now 8 years down the line. The tumor has decreased by about 30%. There's no increase, no metastasis, patient is fine. So this is the biggest advantage of IMRT which we are seeing in our own practice. Not only that, this is the literature data. Humerus, high dose here, humerus is protected. The reason is standard radiation to large volumes of the bone can lead to bone fractures, which again impairs the quality. So that is one thing we have to remember. So IMRT, by constricting the dose, producing concave distributions we call it, is able to reduce the doses to the important structures which we don't want to treat. And data from MSK13 again, extremity soft tissue sarcomas, IMRT, 41 patients, local control 94% beyond 5 years. Of them, 2 had bone fractures, but none of them required a fixation. Now, again, in addition to IMRT, when the patient is treated in a pre-op condition, the same application of IMRT is much more useful because the dose is lesser. We give around 50 gray instead of 60 to 70 gray. And volume is smaller because we need not take into worry our scar or the drain area, and tumors are comparatively better oxygenated at this site, at this time, and reduced cell seeding is possible when surgery is done. Capsule becomes much more firmer and there is lesser chances of seeding at surgery, and therefore pre-op RT is much more useful to be, much more better to be delivered compared to the post-op RT. And however, one data which came out from NCHCI, pre-op RT did produce more early wound complication. However, the latest data from NCHCI says that pre-op RT long-term effects, there is less of edema, less of joint stiffness. Again, the reason is lesser the volume, lesser the toxicity. So, less late edema and joint stiffness. Again, in myxoid liposarcomas, pre-op RT is preferred if you are able to deliver it as an IMRT. In 31 cases, it is from Netherlands. In 31 soft tissue sarcomas, of which 8 were myxoid liposarcomas, pre-op RT of only 50 gray, pathologically there are 100% CRs. And the data from MD Anderson in 127 retrospective data, 127 patients, pre-op RT 50 gray, local control greater than 97% post-surgery. And this is the data, this is one of the figures which you want to show prior to radiation therapy, post-radiation therapy. So this is what generally in myxoid liposarcomas we tend to see, and during treatment itself there is the rapid reduction in the volume. This is planning MRI scan, 324 cc. If this is going to be 324 cc, the mean reduction at the end of RT prior to surgery, it comes down to somewhere around 166 cc. So extremely radiosensitive tumors like myxoid liposarcomas, using an IMRT, restrict the volume, give a high dose, and you will be able to achieve post-surgery good local control. And one more thing with pre-op RT, what is identified recently, which came out in the National Oncology Database, came out in 2011, 5-year cause-specific survival is better in pre-op RT compared to post-op RT. Late effects, we have to remember, irrespective of all the advances, we have to remember that there is a chance of a fracture risk when the dose of the bone exceeds greater than 59 gray, more common when addition of chemotherapy and large deep tumors are there. We prefer a prophylactic fixation if periosteal stripping is done. Conformal treatment, next step we go. We just had a little bit about external radiation, IMRT, which we use literally in RR cases. Next is conformal treatment, brachytherapy. Again, we use brachytherapy a lot in our department. Just to say level 1 evidence, this is from MSK13 again, brachytherapy addition in high grade tumors produces local control of 89%, no brachytherapy 66%. So this is data as old as 1996. So brachytherapy by high dose small volume, surrounding normal tissues, rapid fall off in the doses, and a very good therapeutic ratio are able to achieve. For example, if this is going to be a sarcoma here and this is going to be a tumor bed area, I achieve a very high dose of somewhere around 3 gray per day to this 3 gray per session, somewhere around 20 gray, at somewhere around 2 to 3 centimeters down the line, it is just about 1 to 2 gray. This is extremely feasible with brachytherapy, but it requires a lot of effort, not only from the surgeon, but from the radiation oncologist who needs to be with the surgeon in the theatre for the entire course of surgery and to do the implantation. Another advantage, short overall time. If you are going to use it as a single treatment, dose shaping is possible. Whatever the shape we want to create is possible, only you have to do a good implant. And no need for anesthesia for daily treatment, but it's going to be pediatrics. Brachytherapy technique, be with the surgeon, go ahead by using needles, position the catheters in the tumor bed. This is a literature figure. This is our case, wherein this is a single implant, or it can be a double implant. This is a literature case, single implant. There are about 12 needles which have implanted in this case, 12 tubes which are implanted in this case of sarcoma, high grade sarcoma. And after that, tumor bed clips. Whenever we do post implantation, we always do a CT and a T2 MRI. Here, clips are already placed. It helps us a lot in deciding the tumor bed. We mark it out in the MRI, transfer it onto the CT, and it is done for RT planning. This is the brachytherapy volume we are going to treat, and go ahead with the planning, verify the distribution by means of what we call as the dose volume histogram. We see to it that if I am delivering 3 gray, 95% of 3 gray should be delivered to that volume which I treat. Okay? And RT starts commonly after surgery. Once we do the implantation, we start it around the 5th day. Earlier can also be started, but what is internationally practiced? 5 days post surgery, dose can be given 36 to 50 gray in 6 to 10 fraction as a single monotherapy. If we desire as addition of external radiation, then we limit it to somewhere around 15 to 20 gray, followed for 2 to 4 weeks later with external RT, and we use after loading iridium-192 isotope. Now, this is what our statistics from 1998 to 2009, we have treated less than 15 cases when we did not have orthopedician with us. After the onco-orthopedician came into our institution, this rapidly increased. Over the matter of 3 years, we have done more than 27 cases. The reason is presence of an oncologist who is orthopedician who is practiced in oncology greatly increases the patient, what we want to deliver, the high doses to the small volume, which is aware about it. So this is a big advantage of having an onco-orthopedician in your center. Having some other looks from Cincinnati, 43 cases, brachytherapy alone or with external therapy, local control rate is around 88%. Whatever which is recurred only with brachytherapy, either they were high grade or they had positive margin or they were treated for recurrences. And again, this is from Tokyo. They do quite a lot of brachytherapy works, monotherapy works. In patients whom they have treated, 25 cases, if the patient was treated for a recurrence or for a positive margin, the local control rate is only 43.8%. But when these two are not present, the local control is 93%. So here they advise better combine it with an external RT. And tolerances, we are always worried about whenever the surgeon does, for example, a neurovascular bundle may be closed or it may be infiltrated by the tumor, which the surgeons may not be able to resect it. When you do brachytherapy, is there going to be harm, is there going to be a damage? The literature data says not to worry. Vagus nerve can tolerate 130 in brachytherapy rabbit experiments. LDR brachytherapy data from MSK13, 90 gray, no neuropathy, and again from Tokyo, HDR brachytherapy, 50 gray or combination with external RT, no neuropathy. And these are all well within the doses which we deliver. Pediatric brachytherapy has made a great advances in pediatrics. Again, the points which I told earlier, high dose to the tumor volume, rapid fall off, good therapeutic ratio, no anesthesia. The child just walks into the department. Even if the brachytherapy, they can walk in and have the treatment work out. Even a 1-year-old child we have treated. And bone and organ development preservation, this is the biggest advantage. There is no, in general, hindrance to bone and organ development is the least when we are using brachytherapy. Pediatric works, St. Jude's work from Ohio and from Mumbai. Yes, pediatric works do say that presence of using brachytherapy greatly enhances the local control, and external RT combination with or without it, the control is equally good. Next step, IORT. Again, this is more or less similar to what we say in brachytherapy, concentrating the dose in the tumor area. For an IORT, that is intraoperative radiation therapy, in the operating room you need a linear accelerator, or in the operating room you need a brachytherapy machine. So operation theatre should be constructed as a radiation protective construction room. Okay, you should have that facility. We use electrons post surgery when the surgeon feels whichever the tumor has to be resected, whichever has been resected. If it is going to be, for example, a stomach bed, that area, or retroperitoneal tumor area, we remove the stomach, we move the kidneys away if possible, move the intestines away if possible, or put the shields on those area, and you put a cone on that area which is connected to the linac, and we treat with electrons. Or you place catheters. You can make molds, create catheters, place the catheters in the tumor bed, and go ahead and treat them. The extra time required for this, in addition to surgery, will be about an hour or so. But not available as of in India. We had it in Adyar, but they have closed that facility. So in India, we don't have this facility as of today. In extremity tumors, especially IORT, electron therapy, German data, and they use it for tumors which are more than 5, grade 2 tumors, more than grade 2 tumors, recurrent tumors wherein at least 1 centimeter margin is not likely to be achieved. Here, local control rate, 5-year local control rate is as good as 78%. Again from MSK13, IORT, here they have used it brachytherapy, and here the local control rate is 62%, acceptable late morbidity. Retroperitoneal sarcomas, again they have used IORT. The combined works of Toronto and M.D. Anderson is published by Pollock et al. 64 after the 72 patients in this group completed the pre-op RT, and the loco-regional recurrence-free survival of the 64, 54 underwent R0 or R1 surgery, of them it was 60%. Either they had intraoperative radiation therapy with brachytherapy or intraoperative radiation therapy with electrons. Now what is available, majority of the centers in the world, either the IMRT or the brachytherapy, few centers with IORT, but coming to something called a particle ion therapy, as of today, data has come out, clinical data has come out only from Japan. These are particles, carbon ions are particles, they got ionizing capacity, and these carbon ion particles have been published, data have been published in 2009, 2012, and Chiba Cancer Center in Japan, retroperitoneal tumors, local control 69%, head and neck 80.4%, extremities 76% local control. These cases are the cases which surgery cannot be done, or patient is refused surgery, advanced local tumors. And just to show, this is infratemporal fossa sarcoma, excellent dose distribution, practically very low doses in the surrounding areas, and this is a tumor in the thigh, large pre-carbon ion therapy, and this is 81 months down the line, you don't see anything. But in spite of surgery, though we say that local control, this is from Florida, radiation therapy, 33 patients, this is single institute in Delicato. Lot of works have been published from Florida on the Ewing's tumor, and radiation therapy, 33 patients, 55 gray local control, it is 68%, but when surgery is done with or without RT, it is 100%. So, even in lower extremity tumors, radiation does not become still equal to surgery. But still, one thing, important thing for me to bring to you is excellent limb function is maintained after radiation therapy, no fracture whenever we use hyperfractionated radiation. Pelvic Ewing tumors, similar like what I showed earlier. Here, additional surgery, 100% local control. Only RT, it is only 64%. Again, surgery plays a major role. Whenever surgery is done, addition of radiation, let it be extremity of pelvis, it is superior. And from Europe, the CES data published, this is published in 2003. Local recurrence is RT alone, 26.3%. When surgery is the primary treatment along with RT, it is 7.4%. This irrespective of the size or the site. Surgery definitely is better than RT. When needed, we add on RT. But important things which I want to bring out is inadequate surgery, addition of radiation as a post-op is useless. When narrow surgical margin is expected by the surgeon, prefer pre-op RT, no use of post-op RT. And post-op RT is beneficial only in poor histological responses, less than 90% responses. Italy study, again, same thing they say, inadequate surgical margin, local control is poorer, post-op RT is no benefit, definitive RT is preferred whenever there is suspicion of when you're thinking there is going to be a suspicious margin. Let it be in central tumors or peripheral tumors. Vertebral leavings, again the same. Here, the CES data, 6 patients treated wide resection and with RT, no local recurrence. When RT alone is used, local relapse can be as high as somewhere around 28%. This is much better when surgery is done. Florida series, again, 6 patients with surgery and RT have excellent local control. 5 local control overall is still better in them. St. Jude's Hospital. This is the one thing which I want to show it as the final slide here. Now, Ewing's tumor has transferred primarily from our side to your side as a surgery, but as of today, like what I showed in soft tissue sarcomas, with advances in technology, what can be achieved? I got this only an abstract data. Again, GTV is marked in MRI, which we do for all our cases for soft tissue sarcomas, the gross tumor volume. The clinical tumor volume is marked with small margins, and extra, what we call as a planning tumor volume is marked, and 3D CRT RIMRT is delivered, 45 gray, followed by another 9 gray or 19.8 gray. With this, the local control rate as good as surgery, 95.5%. I could not come across the late effects data in this data. So this is one of the things which I want to bring it to your notice, that like what we have in soft tissue sarcomas, when we apply the advances, like what you do in surgery, when we apply the advances developed in radiation therapy, we will be able to have such high local control rates even in Ewing's tumor. To add up all the things which I have given over the slides, this curve helps us as a radiation oncologist and you as a surgeon. This data helps, nomogram helps us to decide which cases probably go in for a treatment. If the case goes in for a treatment, we prefer, if it is feasible, always for a conformal treatment. Addition of brachytherapy, if it is feasible, extremely useful. And in Ewing sarcoma, again, similar such data in a bone tumor, we are able to achieve extremely good local control. Thank you.
Excellent talk. I've got a few interesting questions for you, though.
I can't get you, sorry.
The first question is that when you treat radiation, in general, you treat the higher dose to the tumor, and then you go several centimeters outside to a lower dose. Is that correct?
Yeah. Around the tumor with about 1 to 2 centimeters gets somewhere around, if it is going to be a post-op case, it gets somewhere around 60 to 70 gray.
So let's say pre-op. So we're talking about pre-op case. So
pre-op casing, we give only 50 gray for the entire volume. The reason is, in the pre-op, if I'm going to give a very high doses, it may not be easy for the surgeon to go ahead with the surgery. Complications can be higher. So we limit the doses to 50 gray if it is a pre-op.
So we limit the dose to 50 gray pre-op, but you give the highest dose to the tumor, and then you give a little bit lower dose to periphery, and you go several centimeters.
Yes, up to 4 centimeters beyond the tumor area, we go to 50 gray. When we say 50 gray beyond the tumor area, the tumor, because of IMRT, gets somewhere around 55 to 58 gray. It does, the tumor, the gross tumor gets much higher dose than the periphery. Periphery gets a minimum dose in the volume which is going to be operated is 50 gray.
So that's why I always challenge my radiation oncologist why we do that, because the tumor we're going to surgically remove, and I don't really care that the center of the tumor is dead. I care that the periphery of the tumor is treated, because that's where my close margins are going to be. And I never got a really good answer why, other than that traditionally that's just the way we do it.
If the volume to be treated, when it becomes larger and larger, the complications set in more and more. Let it be pre-surgery or without surgery also. All our cases, when the volumes are larger, the complications are more. The idea of majority of the soft tissue sarcomas, if we take it correctly, possibly mixed liposarcomas may come out in the years to come with RT only, we do not know. But all our sarcomas as of today need surgery. When you are going to do surgery and the volume is going to be bigger, the complication the patient gets tomorrow. Surgery produces a good limb function. If it is not going to resect or if it is not going to do an amputation, radiation should not add up or worsen this function in any way. So, reduce the volume or reduce the dose, one of the two. And whichever is optimal, for example, a dose of 50 gray to the periphery and a dose, 50 gray is adequate for what we call as a microscopic disease. And for the large disease, because we give 50 gray, dose is automatically higher. I think this is what the data as of today which we practice.
So, anyways, I think we always are talking about that.
What he is telling you is different. He is saying, see, this is a sphere of the tumor. That is going to come out surgically. What we are using radiation for is to sterilize the margins.
Margins, which we give around 50 gray.
So, why can it not be possible that you spare the tumor area, but concentrate or focus your radiation only on the periphery that we want sterilized? So that overall total dose could be reduced, maybe the toxicity could be reduced.
No,
the tumor's coming out, we don't really care.
This concept of idea do not come in, because we are treating a tumor. When we are treating a tumor, when we are treating the periphery, if the center tries to grow, the possibilities are we are not treating the tumor then. The tumor, there is still a possibility it can spread. There is a possibility of tumor spread from the center is still possible. Second thing, we do not know that. I am just thinking of the possibilities. There is no the answer to this. Second thing is yes, and how do we mentally agree to this point that I am not treating the tumor?
Well, that's what I'm saying.
Surgeon is treating the tumor.
No, I am treating it.
So, one other quick question too, is that another thing that I challenge quite a bit, and that is that when we look at the data, that the data unfortunately hasn't compared directly, but we always give 50 gray of radiation preoperatively.
Yes, generally.
And if we're going to do post-op radiation, we give 60 to 64 gray.
Yeah.
And we know that there's no difference in the local control with that, and there's difference, and we all know about some of the complications. But there's never been any data to show that you have to give 64 gray post-operatively. Why don't we just give 50 gray post-operatively? Because if you look at the data, this started when Herman Soot did pre-op radiation. He said you only need to give 50, and MD Anderson was doing post-op radiation, you need to do 64, and we just live by that. But I'm not sure there's data to show that you have to give 64 post-op.
Carcinomas.
Post-operatively, you should require less radiation because you are certain you have cleared the tumor.
Right.
You're only going to treat the margin. Why should it require a larger dose?
No, you are talking of post-operatively, why do you give 60 to 64?
Why do you need a bigger dose?
No, I'll put it the same way, I'll come to this. We relate this to other tumors like carcinomas, where in example, let's take a carcinoma of the CA breast, where it's a carcinoma, here we're talking about sarcoma. The radiobiological experiments show that cell survival curves are much more poorer, that is, tolerance to treatment is much more higher in cell lines which are sarcomatous cell lines, mesenchymal cell lines compared to carcinoma cell lines. When we are able to achieve in a post-op CA breast, for example, a mastectomy has been done, we deliver a dose of around 50 gray, that seems to be adequate. This has not been more or less transferred in a sarcomatous setup post-surgery. Here, in a post-surgery case, 50 gray probably is an inadequate one, because again going back to the biological theory, so we give a higher dose to sterilize it. That's the main reason. Second thing is, your question is, when you are giving an existing tumor 50 gray, question is, why not in a post-op setup give 60 gray? I would love to give somewhere around 70 to 80 gray for existing tumor, but 70 to 80 gray literally is going to produce a wooden limb, let it be a limb. And the 70 to 80 gray, why should it be given? Idea is to preserve the limb. And the idea is preservation with two methods of treatment. One method of treatment takes care of the periphery so that nothing spills during a surgery, and you are going to do surgery. When you are going to do surgery and remove the primary tumor, I am not much bothered about giving a very high dose to the primary side.
Exactly, we are not arguing for giving more radiation.
Yep.
We are arguing for giving
Less.
And what we are saying is that if 50 gray was enough pre-operatively with the tumor still present.
Not enough, not enough. 50 gray plus surgery is enough.
But surgery plus 50 gray, how will it change?
The reason is, 100% zirka, here is a non-handled tumor, oxygenation is good, that's what I am telling. Oxygenation is good, volume is, we take 2-3 things into consideration. Good oxygenation, tumor existing compared to the post-op setup, the volume which we treat is also smaller than this. Smaller volume, good oxygenation, better responses to treatment with 50 gray, and combination of the two is superior always when we don't combine. When we do surgery and then when we are treating, it is a hypooxygenated setup. Microscopic disease, however, in a microscopic disease, in a hypooxygenated setup, in a sarcomatous cell lines, it has been identified that they require a much more dose than a carcinomatous, which is 50 gray. Here it is 60 gray. That's the reason it came out.
How come you don't need radiation post-op after having given pre-op? You are handling the tumor there which is not completely dead.
But we have sterilized the tumor, and you are not going to possibly spill the tumor.
No, but in 50 gray, if you have sterilized the tumor, why
Not sterilize the tumor, sterilize the periphery. We not sterilize the tumor.
So here we have removed the tumor with a margin. With a margin.
Yes.
So actually the volume of tissue which needs radiation is lesser, not more.
The idea again, in the pre-op setup, the idea is the spill can be avoided in a radiosensitive tumor.
No, but we are assuming we are not spilling the tumor at all.
See, if there are setups which you don't treat, that's different. What has developed over the years is this biology, na?
Because that's what we are saying, is that why can't somebody like you now start thinking differently?
Exactly.
And come up with
That's the question.
different algorithms.
The randomized studies too, I showed level 1 evidence.
We prepare a different hypothesis and we do the randomized study, then this is adequate.
We agree with everything that you say. We're challenging it so that maybe we can do better for our patients and give less radiation and still have the same local control. Because right now, we're removing the entire tumor, and it's the microscopic disease that we're worried about. And maybe there's never been a study to really look at 50 gray is all you need with good surgery to sterilize that wound. We go by the theory and all the theory that you're talking about and everything else, but we're treating theory, but there's never been a randomized trial to show that you don't have to give that much. And that's the question I have.
No. Yes, you're right.
So one last question that I think is interesting, because we're doing it, and I don't know why we're doing it, is that when we have in soft tissue sarcomas a positive, microscopic positive margin, we always review it at conference. We say, okay, we got a microscopic positive margin. It's right around the vessels. We don't want to go back and re-resect that area, so let's just go give a boost of radiation. To my knowledge, there's no evidence that shows the boost of radiation makes any difference.
No,
we do
it
it all the
doesn't.
time.
It is not worth it. We always ask the surgeon and posterior margin to go out with the resurgery. That's still preferred one than boosting that area with a higher dose.
That's what I'm saying. So if we don't do surgery, we boost the radiation, but there's no data that says that boosted radiation makes a difference. But we do it, and I just always challenge them.
No, we don't do it. We always say whenever there is a suspicious margin or positive margin, surgeon goes ahead. When there is a margin is unknown, suspicious or positive, we always ask the surgeon to go ahead and remove it.
But if he doesn't, do you do the booster radiation?
If it is small one, we do a brachytherapy. If it is a larger one, possibly we do a radiation.
That's what I'm saying.
Not always, possibly. Because
our group is the same way. We surgically try to do everything we can, but if we can't, they elect to do the booster radiation, and I always challenge them. There's no evidence to show that the boost radiation does it. But so I think what we do is we're treating the theory of the things rather than really what's going on and treating the patient. And we think we're doing better by giving more radiation, but when you look at the evidence, it probably doesn't make a difference. And we're doing the same thing. I'm just trying to challenge our decisions, you know?
Thank you.
It was a very good lecture.
Thank you.
Very, very good. Thank you.
Do you always radiate over a megaprocesses in an Ewing sarcoma with a response less than 90%?
I never radiate a Ewing sarcoma. I
You
mean,
never post.
well, I never radiate a Ewing sarcoma if I operate on it. And if I have positive margins, I will give it radiation. What I'm saying is that we try to surgically treat all Ewings. And if we have negative margins, we don't radiate. If you have a microscopic positive margin, we would certainly consider radiation.
But with wide margins and a poor necrosis, we would still
Less
not
than
radiate.
90%, which European data says we treat.
Yeah. No, because, again, what I'm concerned about is overall survival and not local recurrence. Because that poor prognosis doesn't mean an increased local recurrence. It means overall poor survival. And more radiation is not going to affect the survival.
Exactly what I had told him.
We both really
We're thinking too much alike.
Now I think he will listen to me.
The other thing is that I'm not sure, really, I've probably lived too close to Herman's suit, is that, you know, everywhere I go, you know, we talk about if you have a microscopic positive margin with Ewing's, you radiate because Ewing's so sensitive to radiation. But if you have a microscopic positive margin with osteosarcoma, oh, you need an amputation. Well, Herman's suit, we treat osteosarcomas all the time with radiation. You might have to give it a bigger dose. It does respond, but you might have to maybe give more radiation. But, I mean, most of the country, well, I mean, most of the world, it's like, oh my gosh, a positive margin on sarcoma, you just got to amputate it. I'm not so sure that's true.
No, let's say osteosarcoma is not as radiosensitive as Ewing's.
It has got what we call as a potentially lethal damage repair is very high in there.
Yes, but,
They are not
no,
reduced.
but now suppose you have got a microscopic contamination.
Yeah.
Would it
In an
respond the same
osteosarcoma.
way? Yes. Would it not respond to the radiation in much the same way as the soft tissue
There are
sarcoma?
data from years which we have talked in a tumor, but also I don't generally still accept it. How good
Do
it
you
is.
think that osteosarcoma is less sensitive to radiation
Least
than the soft
sensitive.
tissue? Than the soft
Yes,
tissue
then
sarcoma?
soft tissue sarcoma.
It is the same.
No, so far we know the data is available, it is poor. It is poor. They are sensitive, because there is something called, that's what I told now, this biological mechanism called potentially lethal damage repair is very high specifically in osteosarcoma. By the way, one more thing which I wanted to ask you, how commonly you people use brachytherapy?
We're using it more and more. I think it's advantage. We've got a very good brachytherapist person at our institution, and what we do is we weigh out the risk and benefits of every patient, and so we use it almost every week. We use that, and we weigh out external beam versus brachytherapy. So I like the brachytherapy. I think it's a good option.
Because we do that around, the biggest change we saw in our setup after we joined, prior to that we were just in 10 years only about 15 cases. After we joined, every month we have a case or two.
Yeah.
Now, that's a big thing which we think when the oncosurgeon, when the orthopedician is an oncosurgeon.
Yeah,
Orthopedician, say orthopedician being an
I told you
oncosurgeon is
he's
entirely
surgeon friendly.
that is right. We love you. Well, thanks very much. It was great.
So that's the end of the session. And, end of the day.
Well, thank you very much. I think we really enjoyed it.
Whether it is